Everybody, it's Dr. Eric Balcavage. We're back for another edition of, what are we doing? Thyroid Answers Podcast. I almost said Thyroid Thursday. I've got back my good pal, Dr. Kelly Halderman. She is the co-author of the book, The Thyroid Debacle, which you can see up in the background there. She can do that thing with the Eiffel Tower too, like squeeze it down with her fingers. But I brought Kelly back because I wanted to break down a couple papers, and I thought there's probably nobody better to have do that and have fun with it and kind of explain it than somebody who's super smart cookie, can really look at this stuff and ask some good questions and then have some good thoughts about things. So Kelly, welcome back to the Thyroid Answers Podcast. How are you doing today?
I am doing so great. It is Friday, and so it is awesome. This week has been great. I just got back from an amazing conference and I spoke at it and I learned so much. And so today again, on my end, Dr. Eric, this is going to be the Thyroid Questions podcast because these papers brought up so many amazing questions that I think that even a layperson has. And going through this is going to be educational for me as well. So thanks for having me back.
I think it's educational for all of us. I mean, when you look at this and you start to read some of what's going on here, it really does make you ask a bunch of questions about how we evaluate, how we treat, and what we probably need to change to some degree. So for the listeners, we'll see if you guys really like this, put it in the comments, because I'd like to do more of these down the line with Kelly. And I think it'll be educational for patients, for clinicians, and for us too. So put it in the comments, reach out to me at office@rejuvegencenter.com and give us your thoughts. So why are we doing this? I recently had a podcast with Joe L. Corey. He is a clinical chemist. He's the guy that runs the chemistry labs, kind of sets the standards for what lab ranges should be. This is like what do the people say? This is like his jive or whatever it is. I don't know how they say it. But I had him on the podcast. We talked about labs and lab ranges and how they're interpreted. And for those of you who don't know, my original foray into medicine was as I worked in the hospital in undergrad, in OR, in the ER, and originally I thought I was going to go to pharmacy school. And wound up graduating with a degree in medical technology. And what we do in medical technology is we're the people who are either typically not going out and drawing the labs unless you're night shift, like where I started, because you didn't have any techs on working at night. But we're the people that did all the lab work. So when all your blood specimens, poop specimens, urine specimens, spit specimens came to the lab, like I was one of those people that was running all those tests. So I'm very familiar with all the labs and the blood stuff and testing at that point in time. And then I thought I would go off to medical school after doing that. And then I was convinced by my chiropractor I started seeing in college that, hey, maybe you might want to try chiropractic school. So I went off to chiropractic school instead. But now I'm back, full circle, and I'm looking at all these labs and lab ranges and what we do in functional medicine. And especially one of the reasons we wrote the book was because there's like this problem with how we evaluate and look at labs. So I saw Joe's paper,
letter to the editor based on a paper, had him on the podcast. We discussed it. And I agreed with some of the things. We agreed on a lot of things, but there's things we disagree with too. But I brought Kelly in so we could have a different discussion on this from more of a functional medicine perspective, because he's really living in the world of allopathic medicine. So we've got a couple different papers that we're going to talk about. I'm just kind of read through some of these things and we'll kind of break them down and then have some commentary on these things so that we can kind of get an idea of where Joe is coming from. And just so everybody has a general idea, he believes that there's normal variability in lab ranges, especially when it comes to looking at TSH. And the fact that TSH can vary seasonally Maybe the TSH can vary based on age. And so by looking at TSH only, especially, and narrowing it and sometimes narrowing it down to low, many times we wind up treating people inappropriately.
That's right.
Based on a TSH test. And he looked at some of the literature that says, hey, maybe based on what we're going to talk about, somewhere to between 60 and 90%, I think the number was, of people who are being treated inappropriately, not just based on the guidelines, but inappropriately because of how it actually affects the client over time. So before I kind of jump into the first one, you read through these papers, and you said it brought up a lot of questions, but what was your biggest takeaway from the paper on the first paper, seasonal variation and thyroid testing? So the actual paper, I should say, this is a paper that the title is Seasonal Variation in Thyroid Function in over 7,000 healthy subjects in an iodine-sufficient area and literature review. So when you read this paper, what was your overall takeaway from this paper?
Well, in a nutshell, my overall take was that the allopathic model, which I was trained in, is just becoming more and more antiquated. The more research that we're seeing, the more I'm just screaming inside, how can we be using this model, right? How can we be using this? And so with this paper, it's saying that your TSH is going to go up in the winter months, and then it's going to have its nadir in the summer months. And so, that on top of the fact, like you just said, about the age, right? When you're different ages, you need a little bit more TSH, you need some more stimulation. And so I'm like, I'm so glad we're doing this journal club. I really would like people to ask questions too, because I read this paper and I'm just like, how we have just got to keep getting the word out, because this is medical literature that's saying this as well, that's agreeing that what we're doing is a debacle.
Yeah. And so you would think, okay, well then, functional medicine has it right. And based on this paper, functional medicine may have it even more wrong, unfortunately.
Right. Yes.
Right. So I'm going to read through a couple of these things on this first paper. And this was a study that was done in Japan. We'll kind of go through it. It's a relatively new paper. I think it was 2022, April 2022. Okay, so fairly new study. The first part of this paper, it's like the abstract. They say serum thyroid hormone levels are regulated mainly by the hypothalamic pituitary thyroid axis. So hypothalamus, pituitary, and thyroid. Now, why is that? I already have a beef with the paper. Okay. Right? Because when I read that, I immediately think, well, serum T4 is mainly regulated by the HPT axis, but serum T3 is primarily regulated by the peripheral conversion of T4 to T3, right? So why is that important? Because when we're treating somebody for hypothyroidism, especially in an integrative or functional medicine model, we're trying to manipulate T3. And I don't know if people just don't realize that the thyroid gland doesn't really make that much T3. It only makes 5, 10, maybe a little bit more than that micrograms of T3 in any given day.
The periphery.
And when we then, if we read that and think that both thyroid hormones are mainly regulated by the hypothalamus pituitary axis, we don't think that there's any consequence to providing lots of T3.
Lots of T3.
Did you got the same general feeling from that?
I did, 100%. Mm-hmm.
The next line, I'm already having, my paper's like highlight. The TSH is sensitive to slight changes in thyroid hormone levels, even within the reference range.
and is used as the most sensitive biomarker for assessing thyroid function. So my comment on that, and then I'll let you jump in there. This is true, right? That TSH is very sensitive to changes in thyroid hormone levels in the blood, right? Mm-hmm. But it says that the most sensitive biomarker for assessing thyroid function. The issue is, people might assume that that's necessarily talking about what's going on in the periphery, but it's not the periphery. It's a sensitive, potentially a sensitive marker for what's going on for driving the gland, right? And the reason for that is the types of receptors that are in the hypothalamus and the pituitary. These are the thyroid receptor beta, I think it's 1 or 2, beta 2. And these are primarily dominant in the hypothalamus and the pituitary, and they're like 10 times more sensitive than the peripheral tissues. And that's really important because if we have a drop in thyroid hormone production, we want the hypothalamus and the pituitary, which are kind of driving some of the physiology, to be aware of that very quickly to make shifts and changes. I think the other play, and it's interesting, why would that be important? Well, the other tissues that are really have high concentrations of these thyroid receptor beta 2 receptors, these are really much more sensitive than a lot of the peripheral tissues, are the cochlea and the retina. So why is that important? Well, think about when we're talking, you and I talk about cell stress, cell danger response, the body adapts. What are the cochlea and the retina? That's the ears and the eyes. And so what do I need a lot of times to determine threat from the outside world? Ears, eyes, and I got to tell my brain, do I have enough? Whoa, I got danger, right? I've got to be very alert. And so we want to make sure that those tissues have enough hormone to really support this kind of, hey, could I be in danger, right? Does that
Yep, and that's why they're so sensitive. Yep, that makes complete sense. Mm-hmm.
So I think that comment there is important too, because TSH is sensitive to slight changes in thyroid hormone levels, even within the reference range. So what else might we get from that? That means that we might see alterations or changes, especially when we're prescribing medication, small amounts of prescription changes, I would say from a medication standpoint, becomes most prevalent to me, that when we have a healthy person and a healthy thyroid gland, that person is going to be able to adapt to those changes quickly because they can increase and decrease the thyroid physiology, right? Production. Mm-hmm. But when we're treating somebody and bypassing gland function, or they have no gland and we're just dumping thyroid hormone into the system, we lose that regulatory capacity, right? The body isn't able to do what it normally would do under those situations, like, hey, let me increase this hormone or decrease this hormone due to what my brain is perceiving, hypothalamus, pituitary, and what's going on in the physiology. So I think that's really important because we have to consider that when we're in homeostasis, the hypothalamus and pituitary can make these like lightning fast changes in what's going on. But when we're treating somebody who is not in homeostasis, which a lot of our clients aren't, and we're overloading them with medication, we lose the natural adaptability of thyroid physiology, thyroid glands, and the HPT axis. What are your thoughts on that? I could be wrong, but that's my thoughts.
No, I completely agree. And so you're looking at the author of the paper and they're just missing that giant piece of physiology. So they're making these conclusions, and says in the paper, we can therefore diagnose subclinical both hypothyroidism and hyperthyroidism using serum TSH levels in subjects with serum thyroid hormone levels in reference range.
Mm-hmm. Yeah.
So
what do you think?
It's just their paradigm. It's like how they're looking at this is so different from how we are looking at it. So when you're reading through the paper, it's like, well, if I go back and I was in my allopathic years, I would probably make those conclusions, but it's not the whole picture. And so then the issue is, for the person listening to this, the treatment paradigm. The treatment paradigm, allopathic, is off. And then, like you said, the functional medicine paradigm maybe even more off, which, sorry, bad news, guys, but.
I highlighted that same sentence, and my comment as I read through that was, we can diagnose subclinical hypothyroidism or hypothyroidism using TSH in subjects, right, with serum thyroid hormone levels in the reference range. So we can say, hey, T4, T3, if those are run, most times they're not, only free T4s run, it's within the reference range, but the TSH is elevated, right? Mm-hmm. Therefore, they have subclinical hypothyroidism or hyperthyroidism. And I said, we can diagnose it, but the diagnosis may not be accurate.
That's right.
Because what's the state of the patient? Did they just exercise? Are they fasting? What's the temperature outside, right? What season is it? How old are they, right? What medications are they on? Do they have chronic inflammation?
Do they have naughty children?
Right. So when we look at the TSH, it is often shifting to make adaptive changes in the physiology. Hey, I need more T4, I need more T3, so TSH can stay elevated. So yeah, my comment on that sentence was more like, hey, we can diagnose it, but the diagnosis may be wrong.
Right. You're saying that it would be an appropriate elevation in TSH. And they're seeing it as, oh no, here goes that TSH. And it's appropriate now, but they're diseased. So we're saying, no, that's an appropriate, like you just said, did you just go on a 5K, all those things. And that would be an appropriate response, would be that elevation.
Yeah. So for the person who's like, yeah, but my TSH was at 4.9 and I had hypothyroid symptoms, so I think it's good that they gave me medication, right? Like, well, maybe, but it's not appropriate. We look at the guidelines. Most of the guidelines say you shouldn't be treating anybody until they're over 10. Does that mean that they wouldn't feel better taking some thyroid medication? It doesn't mean that. I'll probably talk about that more. But what we are saying is sometimes, and I think this is one of the things when we talk about Joe's paper or his letter to the editor, if somebody's asymptomatic, but their TSH is out of the reference range, they might get treated with thyroid medication based on the lab values that are not really out of range because they're an older adult, because they are in an adaptive shift in their physiology. There's peripheral inflammatory process going on. So there's an adaptive T4 to T3 conversion reduction, and therefore TSH is staying higher because the pituitary is saying, hey, I need more T3, thyroid gland, help me out here. And so this is one of the issues from Joe's perspective is we shouldn't be treating all of these people, right? Sometimes we're treating these people based on an optimal lab range, right? And this is where he had I think a bigger beef with integrative and functional medicine, where he's saying, hey, people are coming in and they have an elevation of TSH, which could be seasonal or age driven, and they're being put on thyroid medication because they're out of an optimal range, and people won't think it should be between 1 and 2. And yes and no. I think that may happen, but most people, I'm hoping most functional medicine practitioners aren't treating just based on a TSH and no symptoms, right? I don't think that's our thing.
Right.
But I understand if somebody has symptoms and their free T4, maybe the free T3 is within the lab range and they see a slightly elevated TSH, they may
have hypothyroid symptoms too, and the person might say, well, let's just give you medication just to see how you do. I hear that all the time from clinicians.
Yeah.
I don't think it's bad intent of what they're doing, but I think there's potentially negative consequences of this down the line, right? Where, hey, I get a little bit, I feel a little bit better, and then I plateau, and then I need more. And we can talk about whether that's T4, T3 down the line. But did you get this? You had the same thought processes about that as well, right?
Mm-hmm. Yes, I did.
About the next sentence. Did you see? Did you read the next sentence there? Did you have any issues with that one?
Right. In healthy individuals,
Yeah.
that serum thyroid hormone levels exhibit substantial inter-individual variability, resulting in wide reference ranges. However, the intra-individual variability lies within a much narrow range. This suggests that every individual may have a distinct set point of the HPT axis. Now, this is, again, I had a question, kind of pose that to you. It seems more logical. It seems like they're starting to be more logical about there may be a different set point and we have this reference range, but yet there may be, like, based on your unique physiology, and are you sympathetic? Are you being sympathetically driven, or cell danger in that? So that would be
predispositions, right?
Yeah.
So you might, if you're a person who has polymorphisms of the iodinase 2, you're going to have a reduced peripheral T4 to T3 conversion. So your set point for TSH may need to be higher to continue to drive the thyroid gland to make more T4 in reference to T3, or more T3 in reference to T4.
Right.
So I think, so what this means for you, the patient, or you, the physician, is that, hey, we can look at healthy people, and their TSH could kind of be all over the place here. And they show this in the studies. It could be down under 1, it could be up to 5, 6, 7, and these people are deemed healthy. What does that mean? In this study, it meant that they weren't on drugs, they weren't on medication, they weren't taking thyroid hormone, they were essentially non-medicated, not overly complaining of things. They were in for health checkups, whatever that means. So they're saying, hey, it could be down, we test this person this time there, it could be like TSH could be 0.85. That, somebody might say, well, that's too low. Could be even down a little bit lower. Their TSH could be up at 5.02, right? So, and that's above the lab reference range. So from person to person, there's a lot of variability, which creates a huge issue in functional and integrative medicine, who are saying the optimal range is between 1 and 2, right? And so I have to keep medicating you maybe to get that TSH into the lab reference range. And that creates problems. If somebody
that's kind of going backwards, right? I mean, that's really,
right.
I mean, you're taking this comment about there can be this variation, and then in functional medicine, like, oh, we're better than regular medicine, we're going to even tighten this up. It's like, you just missed the variability. Like you said, it could be a genetic, the polymorphism. So go ahead.
Yeah. And so the second part of that, you were talking about, we take a lot of people, there's a lot of variability in TSH potentially. And they could be relatively healthy people, but we could also look at the individual over time, and probably their TSH is relatively stable, right? Did you get you got the same gist from that?
Yep.
Which means we can't have a optimal range. This is really important, I think, for our functional medicine friends. You can't just look at an optimal range and say this is optimal because it's narrower, it's half a standard deviation, it's a quarter of a standard deviation away from the median, or this is because they went through this on their own, that what I like for me is what everybody else should have as a range.
That's the opposite of precision medicine, everybody, right? I mean, all this personalized medicine, we just threw that out and decided we're gonna be better and have this smaller range. But you just heard it, and you can read this paper. It's a pretty straightforward paper. We'll link to it.
Yeah. Next, what about other comments here? The next line. Any issues with that one?
The patients therefore can still be in relative relatively hypothyroid or hyperthyroid states when serum TSH and thyroid hormone levels are within the reference range due to the individual set point of the HPT. What was your comment on that?
So patients could therefore be still in a relatively hypo or hyperthyroid state when serum TSH and thyroid hormone levels are within the reference ranges due to the set point. So we have to think about that.
Yeah.
Are we talking that the thyroid gland is hyper or hypo, or are we talking about the patient is experiencing hypo or hyper symptoms? This is really important. If there's enough, if TSH is within the lab reference range, if total T4, total T3, free T4, free T3 are within the lab reference range, but the person still has signs and symptoms, somebody might say, they have the signs and symptoms, therefore I need to treat. Well, wait a second. My concern is if you're treating somebody based on symptoms, then you're assuming it's just a lack of thyroid hormone in the tissue because the body can't get it there, instead of saying, hey, wait a minute, there's enough T4 and T3 supporting the hypothalamus and the pituitary. There's enough T4 and T3 in the bloodstream. Maybe the cells and tissues are not utilizing it the way we want it to feel good. And then maybe we should be asking the question, why would the body do this? Is that broken or adaptive?
Right. What's going on, that cellular hypothyroidism? What is the root cause of that?
Yeah. And I had a discussion with a medical clinician. Because I'm working with one of their patients, and we talked about how they got on the dose, and they're like, I'm trying to help the patient feel better. There really isn't significant, there's really not that much of a significant consequence of just giving it to them. If I give it to them and they feel better, it must be the right thing. And I'm like, well, if you gave somebody like cocaine and they felt better, is that a good strategy? And they didn't like that analogy, but I'm like, look, so then I diverted and I went to the fever analogy. I'm like, okay, the patient's got a fever. Is the fever the problem? No. Okay. So should we suppress the fever? And they said, why? Yeah, sure. That make the patient feel better. I'm like, okay. But if the fever is not the problem and it is the body's adaptive response to an infection, and you suppress the fever, what does that do to the patient? And they said they feel better. I'm like, but do you delay the healing?
Yes.
And the answer is yes, right? And so instead of having a one-day infection where your body increases the temperature, kills the organism, and tomorrow morning you wake up and you're like, oh, I feel better, you may prolong that infection because you've reduced the immune response. So now I've got a prolonged infection that may last.
I have a story about that real quickly. So I was rounding with a physician who came over to our hospital, and he was from Tokyo. And when we were on rounds, we were going through and someone had a fever, and immediately I said, 500 milligrams of acetaminophen. He's like, why would you do that? Like, what are you doing? And over there, they don't suppress fevers. So, that's a good example of how you're looking at things. So if you're giving your patient, you're going to give them a trial again of T4, and they may feel better for a while, but have they properly addressed what is going on with you? No. Are they trained to? No. So I'm trying to give them the benefit of the doubt, which we always do. It's like you talking to these physicians and clinicians, and that's what they learn. That's like taking, someone who learned a recipe for an apple pie, and they didn't learn any of the other ingredients or how to do it differently. And so it's like, this is why these podcasts are important. And this is why we pick these papers apart, because you're hearing that thought process of there's a better way. So I agree with you.
Yeah. And it is, so for the person who's listening and, they're like, well, I don't feel good. My TSH is normal. I want something to make me feel better.
Yeah.
We're both sympathetic and empathetic to that. The problem is if there's enough thyroid hormone already in the system, but the body's just not converting it to the sufficiently T4 to T3, and therefore you're having hypothyroid symptoms, giving you more thyroid hormone, even though it may temporarily make you feel better, is working against your body's natural adaptive cell defense mechanisms, and it may create short-term benefit, but long-term problem. And I've seen that a lot. And I've got some commentary when we get to the rest of the paper. We're not going to bore everybody with all the details of the sciencey paper, unless some of this, how they do the stuff, some of the study stuff. But I want to just finish with this kind of abstract piece here, and then I'll let you dig in and pull a couple points before we get to kind of the discussion and the conclusion part. It said these set points may be affected. It may be factors related to seasons, and that's the whole purpose of this paper. What they wanted to find out in this paper was, does the season impact your TSH level and free T3 and free T4? And overall, they found that free T3, free T4 really stayed fairly stable, but TSH can swing. So if we're relying just on a TSH many times as the screening test, and there's papers out there, we put it link to one of them in the book, that, hey, TSH is sometimes the one and only test to run to be able to diagnose and treat somebody. If we're relying on a marker that can be influenced by medications and inflammation and age and time of the year, that may be why we've got 60 to 90% of the population of people being treated with thyroid medication inappropriately treated. And maybe one of the reasons why thyroid replacement, thyroid hormone medication is the #1 prescribed medication in the country, is because we willy-nilly prescribe it. And I don't think there's ill intent, but we're looking at, doctors have been taught that, hey, this TSH is such a gold standard that we can just look at that and treat it. And to be fair, I think if we read the guidelines, the clinical guidelines, they typically tell you in the guidelines that people shouldn't be treated until their TSH is probably over 10. And in functional and integrative medicine, we may actually be doing more harm than good and jacking those prescriptions up, because we're often treating somebody if they're 2.5. If their TSH is 2.5 or 3.5 and the patient's hypothyroid and they have a reduced T4 or a normal T4 but a low T3, we're jumping in with T3. Or if their reverse T3 is elevated, we're jumping in there. So we as a community have to be doing a better job. We have to be reading these papers and realizing that it's not just about looking at the thyroid panel and reading, is this value high or low? We have to interpret. And just because somebody is symptomatic and the symptoms match with maybe a low T3 in somebody and a slightly elevated TSH, the elevated TSH may be because there's reduced conversion. And if we jump in there and start prescribing medication too early, we may actually be the people that are creating more thyroid problems, more thyroid atrophy over time. You got any comment to that part?
Add that paper from 2019 about cancer.
Yeah.
That's what really scares me. And I think that people are not aware. It makes total sense. We're seeing just this huge uptick in cancer, and look what the #1 prescribed medication is. So just worth thinking about. This is not without consequence. You're going against the body. So
I think that's the most important thing. We have to take into consideration that even though it seems like, oh, thyroid hormone is just thyroid hormone, there's a consequence, and you may not see the consequence or the impact of that tomorrow, but there may be a long-term impact
And in 2 years from now, like that 2019 paper, 5-10 years out, we don't realize that the impact of that was caused by being on this medication that I started 5 years ago because I was tired, I was fatigued, and my TSH was 3.5. And so my medical doctor wouldn't listen to me. And I went to the integrative practitioner and they put me on it. And I was good for a while. Then I had to increase, decrease, and increase and decrease. And now I feel a little bit better on it, but I'm still overweight. I'm still tired. I'm still fatigued. And I'm needing to increase the doses constantly, or I can't find the dose. It's probably because they were put on that medication at the start inappropriately because the labs they were read, but not interpreted appropriately.
That's right.
Next comments. Where did you go next with this paper that had you a little puzzled, concerned, or provoked some thoughts?
I think, again, we hit on that there's seasonal variations, right? And so the paper does point that out I know I've seen that historically. I live in Minnesota. And so there's things that can affect the TSH level and higher in January and February and December, and then lower in the summer months. Most of my other very bigger questions were in the second paper, Eric. So This paper seems pretty straightforward.
Yeah. And there's something I wanted to point out, and I know it's all median ranges, but if you look at the median ranges of free T3 and free T4, the free T3 median, somewhere mid to low twos.
Low twos, yeah, 2.97.
And upper threes. I don't think there was anybody in the fours, right?
No, there
Which
wasn't.
is interesting because we kind of look at an optimal range. Oftentimes we talk about an optimal range, and some people say 3 to 4. I typically look at that, but based on age, based on a lot of factors, based on seasonally, it could be lower and it could be fine, right? And so this is where the interpretation is. Yes, we use general ranges and say, okay, this is what where we want to see it, but we shouldn't also panic when it's outside that range. I have people like my TSH or my free T3 is 2.5. What should I do? I don't know. Let's take a look at the rest of it. How do you feel? I feel fine. Okay. Well, what's your blood levels look like of the rest of the labs? Well, what's your liver, cholesterol markers, blood sugar markers? Everything looks good. Who cares? What were you doing the day before you did this? So I think that's important for people to know. And I thought what was really interesting was the free T4 ranges were pretty stable. Got down to maybe 0.81, I think was the low point, regardless of the time of which month it was. And the free T4 levels didn't really get above much higher than 1.32, which is interesting because you see free T4 levels in people on thyroid medication, 1.5, 1.6, 1.7, and much higher than that. Mm-hmm. And what we've talked about is that when free T4 levels are too high in the blood, it reduces deiodinase 2, which is the T4 to T3 converting enzyme inside a lot of cells. And so if we drive free T4 too high to suppress a TSH, we may actually be causing that person to be more hypothyroid inside the cells and tissues. And that somebody would say, well, that's why I provide T3, right? I'm gonna give them the T3. But if you look at Bianco's work, he did a paper on this. We chatted on email about this, that when you convert T4 to T3 inside the cell, that T3 stays in that cell, in that nucleus, in that mitochondria potentially for somewhere like 8 hours. The T3 that comes in from the bloodstream is in there for a very short time, half hour to an hour, which may be one of the reasons why maybe a little bit of T3, I get a little boost, but then it doesn't last. Because because of the short half-life of T3, you've got to if you're going to rely on T3, you've got to keep flooding the system with T3 because it has to keep coming in and out, and it's getting broken down faster. The other challenge becomes, as you increase T3, the pituitary
sensing that T3. And if you saturate the pituitary, now you drop TSH. And if you drop TSH and you have a person who's not on a dose of T4 that's fully replacing what the thyroid gland can do, now you're actually reducing the gland's production of T4. Now there's less T4 to get into the bloodstream. Now there's less T4 to get into the cell and be converted to T3 and hang out in the cell longer, which also creates more of a hypothyroid state and the drive for more T3 and more T4 and try and drive those levels up. Last point on that piece is, if you look at the free T3 to free T4 ratio on all of these, if you go from month to month, the free T3 to free T4 ratio is 0.34, 0.35, 0.36 from this healthy perspective. So not down at 0.2, 0.15, 0.17, which is what we typically see in people who are on T4 only, right? Because we're trying to force the T4 high so that we can suppress TSH. And then there is a break point where if you get so saturated in T4, you do get more T4 to T3 conversion via deiodinase 1 and can kind of and that person could feel potentially less peripheral hypothyroidism, but they often have more brain-based hyperthyroidism. And so it's this whole thing gets really sticky. And I understand why a lot of people are like, this is what measure TSH and T4. And that's it. Let's keep it like that simple, because it's hard.
It is hard.
All right. So I think there's a couple other points, and then we'll move on to the other paper.
Can I just chime in real quickly about,
go for it.
About T3 levels? And so I was interviewing a functional medicine doctor, and we were chatting a bit about his optimal ranges for free T3. We're talking about the physiology. And he said that according to Dale Bredesen, and now Dale Bredesen's beginning to be a household name because of the Alzheimer's protocol. So he's a medical doctor. He has this Alzheimer's protocol. And he is waving the red flag that if your free T3 is below 3.2 picograms per milliliter. Thank you. Actually, that'd be deciliter for a
deciliter. I'm sorry. Yeah.
That you're going to get Alzheimer's. So this doctor prescribes T3 to protect his patients and keep that T3 really high. So there's just so much misinformation here going on. And I just wanted to kind of give, because that's what then the people are hearing on this podcast, and he's saying you have to have this, and they're running to get these medications. And again, it's much more nuanced than just jacking up your T3 and your no Alzheimer's. Okay.
Yeah. And I think the longevity paper we're going to talk about talks about, or I don't remember, I've read so many papers, but one of those papers, there's a paper I just read that talks about people with a lower T3 having better longevity, not higher T3, lower levels of T3, potentially being more protective for longevity. So we'll get into it if it's one of these.
Yeah.
So I want to just touch base on a couple of concluding points here. And it's under the mechanisms of variation in thyroid function. And I think we just kind of just talked about this a little bit, but it says, based on the present study, serum free T3 levels, a strong factor in the downregulation of pituitary TSH production and secretion. That goes exactly to what I just said, right? If we start giving T3, let's say you're on 30 micrograms of milligrams of Armour, right? I'm on 30 milligrams of Armour, and what's that going to have? What effect could that have? Especially if there's potentially some cell stress response. I may saturate the pituitary with the T4, the T3, because it's very sensitive to that level. And with inflammatory mechanisms, there can be some increased conversion of T4 to T3 at the hypothalamus. So I take that, and what happens? Suppress TSH. Now I've suppressed TSH. Now I was only taking 19 micrograms of T4 in that dose, right? And so now with only 19 micrograms of T4 in that dose, but suppressed TSH, I'm losing the compensation of the thyroid gland. So now over a period of time, I don't feel so good.
Mm-hmm.
Okay. So the doctor's going to go and like, okay, yeah, we got to get increased. Let's just increase the dose. And so you increase the dose. And then what happens? I've got more T4 that's affecting the hypothalamus. I've got more T4 and T3 that's affecting the pituitary, and I suppress TSH. Remember, those tissues are very sensitive, 10 times more sensitive than the peripheral tissues. And as TSH gets down-regulated, it's going to then have an impact on how much T4. So you keep having to ratchet up the doses of medication, and eventually you put yourself into a state where you wind up on more medication many times than the body would naturally make. And then you're suppressing the thyroid gland's ability to do work and function, and you're actually contributing to the potential atrophy of the gland. Okay, my opinion.
I share that opinion with you, Dr.
Okay, good. All right, there you go. Seems to affect the serum TSH. Okay, suggesting that seasonal changes in thyroid function are peripheral thyroid hormone production dependent. What does that mean? It's that during these seasonal changes, the body is able to maintain the levels of thyroid hormone, and especially the T3, because of what's happening peripherally. Right?
Yep.
So what happens peripherally is influencing potentially TSH. The seasons are having an impact on it, but it's the peripheral conversion that's influencing it, which is really important. Goes to everything Kelly and I have talked about in the thyroid debacle. We pay so much attention to what's happening at the gland and assume it's just a gland dysfunction. And what we're seeing is and this is kind of confirming it, really a lot of what's happening from a thyroid physiology perspective is peripheral tissue driven. Did you get that same take?
Yep. Yes.
The next line, they said, Hefko et al. Reported that experimental acute exposure increased serum TSH and thyroid hormone levels in rats, and suggested both thyroid hormone, non-thyroid hormone dependent mechanisms of changes in serum TSH. Absolutely. Now, that's rats. They're a little bit different than we are. But if you do acute cold exposure, your body's going to adapt, right? There's things that are going to start to kick into gear where neural tissue is going to sense the cold. It's going to start kicking in. Your body's crank up TSH. Your adrenals are going to start to kick in because your body's like, hey, we need some heat. So let's crank it up a bit. And then you go, on the other hand, as a study of cold exposure in humans, that's us, this paper et al. Reported changes in serum TSH and free T3 levels in healthy, reported changes in TSH and free T3 levels in healthy 20 men in Finland. They suggest changes in serum TSH levels are due to photoperiod, and changes in free T3 may be polar syndrome. So I think my notes here, and maybe it's not that big of a thing to talk about here, but I think where it's important, when we're talking about acute cold exposure, is different than somebody who grows up in a cold environment. Their set points are going to be different. So if you take me or Kelly and throw us in a cold plunge, we're going to have an acute response to that, right? Versus if you take somebody like maybe a Wim Hof or somebody who's doing cold exposure on a regular basis, they're probably not going to see as dramatic of adaptive changes because they've adapted to it. And maybe that's a terrible analogy versus somebody who just grew up in the Arctic or Antarctic or Sweden or somebody where it's a chronically colder environment. Their thyroid physiology is going to have a new set point, a new adaptive point where they may not see huge swings or changes like we might see when it's an acute exposure. I thought that was maybe an interesting thing to point out. So the general gist of this paper was, hey, people, when you are getting your thyroid panels done, consider that a slight elevation in TSH, even if it's above 4.5, may not mean you have a thyroid condition, and that needs to be treated with medication. If it's out of range and you're symptomatic, it may or may not mean you need treated. This is where we need to look at more complete panels, a more complete thyroid panel. We need to take into consideration signs and symptoms, and we need to take in consideration tissue markers. If you're not doing that and you're just treating based on a TSH or just treating based on symptoms to help our clients out, probably not the best strategy, right?
Yep.
All right, so we got that one knocked out. That only took, close to an hour.
All
right. So let's talk about Joel's paper here. I'll let you kind of start off there. Now, Joel did a paper that was a letter. It was a letter to the editor. So pointing out some points in this, right?
Mm-hmm. So yeah, this is basically that the person that Eric described, where his expertise is lab values and reference ranges. And he goes in to really talk about the healthy participants, the 7,000 healthy Japanese participants in the study, and some issues with that. And I'll let you kind of, because you interviewed Joel, I'll let you start by kind of outlining really his rebuttal in the letter to editor, and then I can comment on it.
Yeah, so he's really concerned that because there's variation in TSH levels and we use it as a foundational test to treat, right, the gold standard, but there could be seasonal variation, could be age variation, there could be other things that influence it, that this may be leading to too many people being put on prescription medication, thyroid medication, inappropriately, and creating a cascade of problems from a health perspective.
Yeah, and we agree with him from that perspective. And at the end of the paper, he says a mildly elevated TSH result in a normal free T. He says try getting retested in 2 to 3 months later to make sure this is not a seasonal artifact or transient increase before prescribing taking levothyroxine unnecessarily. We agree with that.
Mm-hmm. Mm-hmm. The problem is, kind of one of the premises is we like, especially in functional medicine, we like to run more generally broader labs. And he's got concerns that, hey, if we get more healthy people getting blood work done, that could influence the lab reference ranges and might impact those who should be treated. And it may result in people who are healthy having too high, too low, like too high or too low levels based on the ranges, and causing them to be treated inappropriately. And both of those things I agree with, it could influence them, but only if somebody's treating labs, not if somebody's actually interpreting what's going on. And I think his concern, especially from a functional or integrative medicine perspective, might be that, hey, in functional and integrative medicine, they're running comprehensive panels, broader panels, and then potentially treating people when they may not fit the guidelines for treatment. And it could skew the ranges. I don't think that that's necessarily the case. I don't think the vast majority of healthy people are outliers. I think they have a tendency to be the people that are often closer to the median range. But another part of it is, how are we establishing who's healthy and who's not? How are we establishing who's developing a condition and who's got a disease, right? And isn't that what the lab ranges are set to do, is determine when there's disease that needs treatment? And what we're looking at in functional medicine is saying, is this person symptomatic or asymptomatic, but developing a problem that we can help with diet, lifestyle, and some nutritional support I think that a lot of us in functional medicine aren't prescribing based on these things, or at least we weren't. But now with more people who can prescribe coming into the functional medicine space, I think it does lead toward the tendency for more prescriptions, sex hormone prescriptions, thyroid prescriptions, and other prescriptions to optimize levels into this very narrow range that may not be appropriate.
That's right.
So for the listeners, there's some key things in here that I think are really important. They talk about levothyroxine is the most prescribed drug in the USA, estimated 23 million people who have active prescriptions, and studies have raised the concern that 90%, and it's somewhere between 60 and 90% of the prescriptions are prescribed inappropriately because they were given to patients who were diagnosed with mild hypothyroidism, meaning their TSH was a little bit above 4.5, and somebody prescribed it, maybe with or without symptoms, or they had euthyroidism based on a TSH and maybe a free T4. Those values were in range, but they were still complaining, so they were put on prescription medication. And we talked about this, that, hey, once you get on that merry-go-round or that roller coaster, you're going to be, it's hard to, everybody's trying to find that right reference range. So that's concerning. He goes on to say, the Journal of Endocrine Society describes the effect of seasonal variation. That's the paper we just went through. Now, it's healthy Japanese people. We talked about that a little bit, but there's variability here too. This is in Japan. So we'd say, okay, that's kind of mid-temperate maybe. But could those values have been different if we did people in Finland or around the equator? Sure, they could probably be a little bit different. But they pointed out that the study points out that TSH levels vary through the year, which he agrees with. And I think that's important to realize when you're going to get your thyroid labs done. Don't necessarily have this narrow set, this TSH in mind, and don't necessarily think that just because it's in that range that you're healthy, right? So labs need to be interpreted as thorough a panel as you can get, and then take into consideration that you should expect TSH levels to be higher in the winter and a little bit lower in the summer. So just if you see TSH, hey, my TSH is normally 1, but now it's 0.7. Am I over-medicated? I don't know. How do you feel? How do the rest of your labs look? What's your conversion, right? We need to look at all those factors. And if you're getting it done in the winter and your TSH is elevated, hey, I was, 1.4 and now I'm at 2.6. Oh my gosh, do I need more medication? You may not. That may be just the body's adaptive change. It needs to upregulate TSH to help regulate thyroid physiology in the body.
And I feel like a question that a listener may have is that we're saying that there's variation, right? Between winter and summer months, there's variation between age. I feel like a question might be, well, then what if we just fixed and changed rather the TSH reference ranges to reflect when are you having this drawn and how old are you? Can you comment on that?
Yeah, I mean, we could do that, and we do that with other lab values, right? When we look at, hey, is this a female? How old is this person? And we have to take those things into consideration. And even for me, I'm trying to make sure that I keep that in mind when I'm looking at somebody. What's the appropriate reference range? How old is this person? This person is person 65. All right, so. And I had this conversation with the clinician the other day. The person's 65. You probably shouldn't be suppressing their TSH that low, given what the evidence says that should be probably higher for that person of that age. That's the adaptive change. So I think we could and we should, in both allopathic medicine and functional medicine, integrative medicine, we can't have these rigid ranges that we stick with and say, this is it. And somebody might say, well, but why not just give it to them? And the issue is, it's like you're doing it. It might make them feel good. Yes, giving them the Tylenol may drop their temperature, but it's not long term. It's not beneficial and isn't part of the oath. Whether you're a functional medicine or allopathic medic physician, is first do no harm, right? And so,
yeah, I think it's a step in the right direction, but we have to really make sure to drive home the point of signs and symptoms, not treating the paper, like, right? Because it's like an upgrade to it. Like, oh, look, we have these new reference ranges but that's not where it ends. That's not going to be good enough. Like, in my opinion, it has to be really looking at tissue markers, looking at that individuality and not just relying on new reference ranges. So I think just for the listener, it would be great. And Dr. Eric already does, he looks at your labs like that. That's what he's looking for, but it's not going to fix everything.
No. And he goes in here, he says in here, however, that is, he says the source of the problem lies in how we derive reference intervals in the current laboratory medicine practice. Reference intervals typically do not include at least 5% of the healthy population.
Healthy, everybody, quote unquote, healthy.
Which we don't have a great definition of that. And so that's not, I get his point there, but right. So the people who are outside the reference range, the 2.5%, he's saying some of those are healthy people that could be in that 2.5%. Typically, if they're not on medication, usually if you're out of those ranges, it could be a short-term adaptive change, but a lot of times maybe it's problematic. But this approach made sense 30 years ago when laboratory testing was not accessible, and these tests were mainly ordered in patients exhibiting certain clinical symptoms. However, that is no longer the case, as more thyroid tests are ordered on individuals who do not need them. Now, do not need them based on what? Based on somebody like, hey, I want to go to my medical doctor and I want to get evaluated, and I just want to see where I'm at. I'm getting a healthy checkup. I'm getting a blood draw test done. What's happened, and I want you to comment on this, is in allopathic medicine, when I started and we ran a general chemistry panel, it was like 30, 35 tests. If you get a general chemistry panel done today, it's like a Chem 14, right? There's only 14 tests. And so what gets measured gets managed. So if I want to assess physiology and I'm only running 14 tests, what am I assessing, right? So the problem in what I was taught was you only run the tests to confirm your diagnosis. But what if my diagnosis is wrong, right? Or what if my patient can't really communicate what their signs and symptoms are? Wouldn't it be better to run a more thorough test? From a business model standpoint, maybe not. But this is where I kind of agree and don't agree when he says that they're ordered on people who don't need them. I don't agree with that. If you're going to do a TSH as a screening test to determine if somebody's healthy, but that's so variable by temperature, time of the year, age, inflammatory mechanisms, then why would running a fuller thyroid panel be inappropriate? If you're going to run the test, wouldn't it make more sense to take a broader look at the panel so we can actually see, well, the TSH is slightly elevated above the lab range, that there is good T4 to T3 conversion. You can't do that if you're not running fuller tests. What's your take on that?
Yeah, I completely agree. It's so common now for people to say, oh, my thyroid, it's totally fine. I had my TSH and my T4 checked. Or, oh, and my blood sugar's fine. My fasting blood sugar is 99. Or, I mean, really,
or 86, but nobody ran the insulin to know how much freaking insulin. So for the listener, 86 might be, right? 86 for a fasting glucose might be normal.
Yeah.
Right? Let's say we want it between 80 and 92, right? Let's just say that's the range. And you get 86. Somebody might just say, oh, your fasting glucose is good, no problems. But they haven't looked at your signs and symptoms and know that, oh, they have blood glucose issues, they got tiredness, fatigue, they got reactive hypoglycemic symptoms. Oh, you're a little bit overweight. Like if they didn't take all those things into consideration, they just looked at that, they may say it's normal. It's normal. And we would both agree it's in the normal range. However, what we need to look along with that is how much insulin on this fasted blood lab is it taking to keep the glucose at 86, right?
That is just, I mean, I can't even believe how many people are told just that. Look at your blood sugar. It's great. And then behind the curtain, your pancreas is like screaming, like putting out all this insulin, but you're normal. And then they just let them go down that road because of how they're looking at the labs. They just keep on walking down this path because we're not going to look deeper. We're not going to look, and we're going to say, great. And then all of a sudden your pancreas cannot toe the line. It cannot keep going with that insane amount of insulin. It drops, your blood sugar skyrockets, and they're like, you suddenly have type 2 diabetes.
Right.
It's like, well, we could have told you that if we would have looked at a larger panel.
The reason we're harping on this, and he's talking about thyroid physiology, but if you're going to actually do like a health checkup on somebody and you're not looking at both the fasting glucose and the fasting insulin, how are you ever going to determine that there's glucose or insulin resistance developing? Pre-diabetes is developing, and somebody might say, well, I'll just look at the hemoglobin A1C. Well, that may take years, right? Or I can look at the fasting insulin and go, wow, the fasting insulin is 27. That's too high. Or maybe it's only 12, but it should be lower in a fasted state. Because when does insulin surge? With eating, right?
Right?
So if your fasting insulin is 26 and you haven't eaten in 12 to 24 hours, that means the glucose that your liver is putting out on a regular basis to help run the system can't get into the tissues. You've got some type of cell stress tissue resistance issue. And if we knew that today, we could maybe prevent you from ever becoming pre-diabetic and diabetic. But if we don't run that type of testing, that's why we have people that that have disease, because we're not doing the broader labs and looking for patterns of problems, not whether they're high or low, but interpreting the labs appropriately.
But Eric, so if we started to implement if like the magic wand was waved and everyone got a more comprehensive thyroid panel, would that not hopefully lead to less medication prescriptions?
I think this is Joe's argument, is that it doesn't. It leads to more prescriptions because people are reading the labs instead of interpreting them, right? So that's where I agree with him. So I'm like in this tough position where I don't think he's right about that. I think we have to run fuller sets of labs. We need to run them on healthy people, but it's not about the lab. It's about the interpretation. If we run fuller labs and we interpret them with limited bias as to, oh, but I prescribe this drug or I prescribe that drug, and just say, wait a second, let's look at the lab. What is that? Normal and appropriate, normal and inappropriate, or abnormal and appropriate, or abnormal and inappropriate. We talk about this in the book, but it's so important.
And as a reminder, we created a course, the Thyroid Debacle course for practitioners. So you too can look at a comprehensive thyroid panel and have that deeper, nuanced way of looking at these panels.
Yeah, good point. So he goes on to say in this paper, so as we run, more thyroid tests are ordered on individuals who do not need them He says this significantly increases the likelihood and number of falsely abnormal results. So this goes to exactly what I just said, and I brought this point up to him. He's saying it's falsely abnormal. It's abnormal, but it's appropriate, right? Or it's abnormal, but there's nothing wrong, right? Is that what you take from that?
Yep. Mm-hmm.
But I said to him, Joe, if we're interpreting the labs, we wouldn't make that decision, right? And he's like, yeah, but that's not what everybody's doing. And I agree.
That's right too.
Right. So, right. So he goes on here, he's talking about this. He says a better approach may be to move away from population-based reference intervals altogether to using universal outcome-based treatment cutoffs and decisions for PSH, glucose, cholesterol, all these. But I still have an issue with that as well, don't you?
Yes, I do. And I wanted to definitely go into this. Let's riff on this point for sure.
So if we just say, all right, we're only going to treat people who are definitely outside this range. They have to be above 10 for us to treat for a hypothyroid condition. Those are the people we treat. It's like it's outcome based. The literature says this is what we only could treat here. The problem is we're still not doing a great job interpreting, and so we're not getting the nuance. Like, hey, that person's TSH is only 8, but they don't have enough T4 and T3 in the system, right? So if the T4 is low, the T3 is low, the reverse T3 is low, and their TSH isn't quite 10, it's still a person who needs thyroid hormone.
That's right. That's right.
So,
it doesn't fix changing to that model doesn't really address.
Doesn't fix it. And the issue would be here too. Okay, where we're going to use outcome-based treatment. So we don't put people on medication for elevated glucose until they're at this range. And I agree with that part of it from a drug perspective, but that doesn't mean this person shouldn't start getting interventions earlier, right? If their fasting glucose is 102 on a regular basis, we need to interpret that level. Hey, their fasting glucose is 102. Their insulin's 5.6. Okay, that seems normal for the insulin. Is it inappropriately normal, right? Is the insulin inappropriately normal? What's their T3? Do they have enough T3 to do it, right? To help drive the pancreas function? Is it that they're just a person who gets stressed when they go get a fasting blood draw done and they were rushing in from dropping their kid off at school, right? So is that artificially elevated? So, you know, we've got cholesterol. How many people are on statins because of what somebody's outcome-based treatments say?
That's right.
Sure. We lower, we wait here and we treat. That's why cholesterol is lower and lower and lower, and we're treating it because, hey, that level doesn't reduce cardiovascular risk. So let's drop it again and see if we can reduce cardiovascular risk. So I may be wrong in how I'm interpreting, but do you interpret the same way?
I completely agree with you. It's like you're walking down the path of blood sugar dysregulation, right? And suddenly you get to that fasting where it's above 126 and you are slapped with a diagnosis and given a medication. But did you change the path? You're still on that path. You never changed it. And that's what they're saying in this paper. He's presenting that is that if we hit this range, then we can all agree that this is high cholesterol. And this is your diagnosis. But that you didn't change. You didn't get off the root cause issues. You're not changing your physiology. You're not addressing it.
Right. And so I think that's his paradigm, right? Because he's living in this world of drug treatment or medical treatment. And we're looking at this from a perspective of a functionalist and how do I evaluate health and well-being and how do I restore it? But where it gets really dark and murky is when we've got functional practitioners who want to start prescribing or integrative practitioners who want to prescribe too early and really start muddying the water. And I think that's where he has his biggest beef with. Because he thinks that that's really what functional medicine is, and it really isn't that.
It isn't. But it is because a lot of people are doing that. But it shouldn't.
And we say this in the book and we talk about this, but functional medicine is about addressing root cause. And I think what's happened in functional medicine, and listen, people can disagree with me, with you, and I could be totally wrong. I'm okay with that. Just show me where I'm wrong, and I'm willing to change my viewpoint and opinion. But functional medicine should be about addressing root cause. And too many people think addressing the root cause is optimizing blood levels with drugs or medications or supplements. It's not. That is not addressing root cause. For the listener, I just had this happen this week. I have a patient, new patient. They're on magnesium and zinc and selenium and all these different supplements. And I'm like, why are you on all of these supplements? And they're like, because they had a, not sure if they had a hair tissue mineral analysis or a micronutrient test, and forget which one it was, but they said, my doctor said I'm deficient in all these nutrients, therefore that's why I'm taking them all. And I'm like, okay, first of all, if you're deficient in 12 or 14 micronutrients, then you got a diet problem, a digestion problem, or a gut problem, right? And so putting more in, and I said, then the second thing is, and we've talked about this multiple times, just because you put something into the system doesn't mean it's going to work the way we want it to and show up on a lab the way we want it to, right?
Right.
So it's too naive. We think it's a linear path. I put magnesium in, it's going to do exactly what I want it to do. Maybe not. Maybe because of other things that are going on, you're putting that magnesium in, but because you have fat malabsorption, you're peeing it or pooping it right back out again. Maybe the high stress is causing it to be depleted. Maybe that magnesium isn't going to support methylation. It's going to support a different pathway that's going to help support inflammatory mechanisms. So we get a little bit naive. It doesn't mean that, Kelly or I wouldn't say, oh, you got some magnesium deficiency, you should probably take some. But we have to step back and take a look at what's the bigger picture here. Why is this occurring? Right?
That's right. That's right.
So he goes on here to say, he thinks this approach makes more sense, especially considering that major recent studies have found that no benefit of treatment with levothyroxine unless TSH exceeds 7 to 10. Now, this is an arguable point, right? There's a lot of people that would say my TSH was 6 and I felt better when I got the medication initially, right? But then that starts the roller coaster. But if you look at some of these longer term studies treating people that soon, and they look at over time, these people don't feel and function better over time. But they get the first hit or the second hit and they feel better. You know how this is. We've had this discussion, right? Like, hey, I feel a little bit better. That's good. But that isn't necessarily what's best for your overall physiology, right?
No.
It says treatment of lower levels of TSH has not been shown to provide clear benefits in randomized controlled trials, yet most patients with TSH values flagged as abnormal based on population-based reference intervals are treated with levothyroxine. And they are.
They are.
Even though, but why? And we're going to blame the medical physician, the allopathic physician, for maybe not doing it. Say, hey, they're not listening to me. They're not giving me my drug. They're not giving me, I should be on it. I have these signs and symptoms. But understand the guidelines are not to do it. It doesn't mean you don't have hypothyroidism. It doesn't mean, or hypothyroid signs and symptoms because of reduced conversion. But what those levels and the guidelines are saying, do not provide thyroid medication too early because A, it's probably inappropriate. Long-term, it's not going to be beneficial. And 3, it may be problematic in time because you're losing the normal adaptability of the HPP axis to help regulate thyroid physiology. So that part I agree.
Mm-hmm.
And we think we're doing better. Oh, I'm going to go to the functional or integrated practitioner and they're going to give me my drug. And we think that's better, but it falls into this issue where now are we treating somebody inappropriately to optimize their blood levels? And the optimization of that is going to create a cascade of problems down the line, which we talked about before. And we talked about that 2019 paper on different types of cancers and how the incidence of multiple types of cancer is increased in people who get put on thyroid medication. And there's more and more papers today talking about how the downregulation of thyroid physiology is likely an adaptive response in many cases and not broken physiology, which is what the premise of what we've been talking about. All right. What else? We covered this paper. Anything else on that paper you wanted to talk about?
I don't think so. I maybe the last point, and it's in the paragraph that we were in, is overtreatment with levothyroxine also comes with its own risk, particularly for the elderly who are at increased risk of harm. Now, so my husband is a Mayo Clinic doc, and he does anesthesia, so he sees everybody's medication list. And it feels like everybody over the age of 65 is on Synthroid. And so it's like, we can identify it in the literature, we know there's harm, but yet we're just on the hamster, we'll just keep on keeping on. So that's why I think continuing to talk about this and discuss this and educate the listener on what's going on, because as you get older, I mean, we definitely don't need to be, we need to look at TSH differently in the elderly. We need to look at all the thyroid physiology a little differently.
Yeah, and it is a shame, because once someone gets put on thyroid hormone, it's assumed that it was done appropriately. And what we've talked about so far is that maybe it wasn't in about 60 to 90% of the people. And two, it becomes difficult. Rarely, I don't know. You would maybe know better from an allopathic perspective. But I think once they're on it, they're always on it, right? Because they got a thyroid problem. We got to keep them on medication. And the focus isn't on, was this given appropriately or inappropriately? The focus is it's assumed that they have the condition and their thyroid can't work. And now the focus is on making sure we get them on the right dose based on a TSH that's trying to move based on what's going on in the physiology. And we're working against it the whole time. The literature is pretty clear that as people get older, the TSH levels rise naturally. It's just part of what happened appropriately. So big change. And I don't know, just Chuck read that I'm not trying to throw Chuck under the bus, but does he read a paper like this and say, or is it like you were like, this is what we do? Like, did he start to think like, hey, maybe some of these people aren't, or is he just so busy and those people come in and it's like, I'm not the prescribing doctor anyway, and think that, hey, maybe this is part of the possible issue?
The latter, that he is so busy and not the prescriber, and he's just trying to keep them alive and breathing and getting them out of their surgery. But yet he has read our book. He's read it twice. And so he knows that this is most likely inappropriate. And so, not to go too far into this, but I just had my mom, who had a comprehensive thyroid panel drawn. Her TSH was around almost 8, 7. She's not having any symptoms. She went to her regular physician, and the physician just was like, here's your Synthroid. Oh my gosh, and I mean, just didn't even listen to her about, well, I'm not having any symptoms. I mean, it was such a knee-jerk reaction. So I just don't think those in the field, I don't think it's getting any better. And like you said, I think it's very important. I knew that when I was prescribed Synthroid, I knew that this was going to be it scared me, a lifelong medication, because I didn't know you yet. So getting off of it is interesting, but Dr. Eric makes it a lot easier. And there is hope, guys. There's hope too. I mean, I'm just going off of it and restoring the physiology, but back on track.
I want to, you brought up a real important part about your mom and the TSH at 8. And this is where we really need to interpret, right? As an older person, what's their signs and symptoms? What do the rest of their labs show? What does the thyroid panel show? Is she converting T4 to T3 in a more optimal range, or is it not converting really well? But I just did a Thyroid Thursday on this on bone density. I don't know if it got released yet, but if you have too much thyroid hormone, we know that hyperthyroidism is associated with osteopenia and osteoporosis, right?
Yep.
So in hypothyroidism, there's less bone remodeling. So for the client, you break down bone and then you build it up again. And when you have hyperthyroidism, the thyroid gland is making too much thyroid hormone, you accelerate the rate of breakdown in relation to the amount, osteoclast versus osteoblast. In hypothyroidism, when you don't have enough thyroid hormone, there is reduced remodeling. So you wind up holding on to the same bone for a longer period of time. That can create its own set of challenges and problems. But what the literature shows, and this is another one of those things where you go, what the heck are we doing? If we're prescribing, if somebody's had that tissue hypothyroid state going on, and then we start giving them thyroid hormone replacement, it accelerates bone loss in those people. So that doesn't mean they don't need it. Right? They may need it, and that can increase the breakdown because of how thyroid physiology works. And I think it's because we're not differentiating the people who are in homeostasis versus allostasis, right? In a cell danger versus not, and they just need thyroid hormone. Mm-hmm. But now consider this. If you're an older person and your TSH is elevated anyway to help offset maybe some peripheral reduced conversion, and now somebody gives you more thyroid hormone that you really don't need, could you be accelerating their bone loss? And the answer is, based on the literature, yes, because you're creating a hyperthyroid state in that older person, and you may be speeding their risk to osteopenia and osteoporosis. You're not helping them, you're potentially creating more compromise.
Yeah, I'll have to watch that Thyroid Thursday. That's a bomb.
So I think we only got through 2 papers, Kelly.
That's okay. But, I mean, we did our due diligence that they need, and better to go in and be very verbose about things and really get into it than just skim over it. So I'm proud of us. I think Journal Club went very well today. I would love to hear the comments and read them and digest them and see where you may have questions. I tried to, in my mind, kind of formulate some of the questions that I think a listener would have. So we tried to address some of those, but we could do another Journal Club on the other article.
Yeah, I'd love to do that. So we'll schedule a time, and maybe we will do this on a monthly basis, pick a paper and kind of go through it. But for the listener, the paper we didn't get to was one called Longevity, Demographic Characteristics and Socioeconomic Status are linked to triiodothyronine levels, T3 levels in the general population. And there's some really...
This is a good one.
There's some really interesting points in this. So I think we'll do another one. We'll kind of really dig into that paper. And see, and then maybe we'll keep this going and put this out as like a bonus episode each month we'll find a paper and kind of break it down, talk about it, highs and lows, and then what that means to the patient, for the clinician. And so maybe we can continue to change the conversation about how we evaluate, address, and deal with thyroid physiology.
That's right. And send us papers too to office at Rejuvigen Center. Send if you have a paper that you'd love for us to pick apart. We'd love to hear from you.
Yeah. All right. So we're going to wrap it up. You're going to get on with your day.
Yes.
Have a great day, great weekend, and we'll chat soon. All right.
Okay. Thanks, Dr.